Hello, friends. Good morning, good afternoon, good evening, where you are from. So, I'm Mohammad Saghir Khan, uh, co-chair of SIOP Global Health Network and part of SIOP DiSPLeN team, disease-specific portal for learning and networking. So, we are having this webinar, Strategies to Improve Outcome of Wilms Tumor, SIOP Protocol and Treatment Adaptation in Low Resource Settings. We're really glad to have two pediatric oncology experts. Dr. Trijn is real from Netherlands. Was one of my mentors in SIOP Global Health Network, the former PODC, and she's leading SIOP Wilms Tumor Africa project since long time. Really glad to have her as a co-chair of this co-moderator for this webinar, along with Gabriela Villanueva from Argentina. She's the part of SIOP DiSPLeN team. She's a part of SIOP Global Health Network. Thank you so much for taking as moderating this very important webinar. So about DiSPLeN, if you have attended the previous webinars, you know about it. Just to tell you that this is a new initiative. This is specific portal for learning and networking, which is SIOP GHN's initiative to provide additional learning avenues to SIOP members. Learning forum on various aspects of care directed at common curable cancers. We are providing various learning sessions on case-based discussions, diagnosis and referral pathways, access to care, advanced diagnostics and therapeutic modalities on various common curable cancers. The invited faculty are the SIOP members with enormous experience and expertise, which are the disease experts, and DiSPLeN enhances SIOP membership engagement and contribute to professional nurturing of SIOP GHN members. So we are in the pilot phase, which is running for the 6 months starting from December 2024. So it will go by the end of May this year. So the basic aim is to globalize the already existing smaller and regional groups on disease-specific learning. DiSPLeN team is going to coordinate Education Day, which I'm just going to display, along with the local SIOP Asia organizers during SIOP Asia 2025 Congress, which is to be held in Riyadh next month. Our ultimate goals are to expand the project to non-English languages, to engage global representation, connect with other projects with SIOP and SIOP continental branches, and actively interact with key global stakeholders and childhood cancer initiatives. So we already have three very successful webinars, first two on neuro-oncology, low-grade glioma, then medulloblastoma. And the last one in March was on updates on advanced pediatric Hodgkin's lymphoma. These are all very well attended, very successful, very interactive sessions. And gladly, we have recording of all these sessions available on SIOP YouTube channels. And this webinar is the fourth one on Wilms tumor, and the next coming up will be on ALL. That will be end of April. So you can use this QR code to go to the SIOP DiSPLeN web page to get more information. And the next month, as I said, SIOP Asia, which is going to held 12 to 15th of April in Riyadh, we are going to have two tracks with all WHO 6 and 6 index cancers included, 6 sessions on Education Day on Burkitt's, Hodgkin's, ALL, Wilms tumor, retinoblastoma, and brain tumor. And you can see there are world-renowned experts on various diseases and so many other Asian representatives, folks who are the part of the either speakers or the panelists of these sessions. So these will be all very interactive sessions as we do here. So those who are attending SIOP Asia or planning to attend, just sign up for the Education Day. There is a QR code which will take you to the SIOP Asia website. So we're glad to be receiving you, welcoming you in Riyadh next month. So some housekeeping instructions. So the questions, you can ask the questions clicking on the question at any point. Unfortunately, there is no voice option for the audience because with very little time, 1 hour duration only. The text answers will come from the experts if possible, and we would take dedicated question and answer time after the presentation. In the end of the presentation, end of the session, you will get a survey for your feedback. And we will get the certificates of attendance also after filling the feedback. So we will really appreciate if you go and fill up the survey and participate and give your feedback about this the DiSPLeN product. Let me hand it over to Gabby for taking you through the next part of the webinar. Thank you so much.
Thank you so much, Tahir. So we are going now to move forward to a clinical case that is going to be presented by Dr. Debora Berdecio. She is a pediatric resident at Hospital Pedro de Lizalde in Argentina, and she's presenting to all of us one of her cases at her hospital. So Debora, go ahead.
Hi, thank you very much. I will share my screen. Can you see it? Well, my name is Debora Berdecio. I'm a second-year pediatric hematologist resident here at Hospital Pedro de Lizalde from Buenos Aires, Argentina. The case we will start talking about is about a 3-year-old female patient with a complete immunization that had, I'm sorry, my screen is sharing a little bit weird. I can't see it.
We can see, it's
You
okay.
can see
We can, yeah.
So, like all the screen, all the, oh, wait, 1 minute.
Do you want me to share, Debora?
Yes, please. Maybe I had a little bit of, I don't know what happened. Yeah, yours is also a little bit rough because it's mixed up, but it doesn't matter. Well, it's actually your female patient that came to our service 2 months prior, her first, her first episodes. And family aspects, she had non-related, she had all her immunizations were complete. She also had only isolated episodes of bronchoobstructive pulmonary disease and constipation. From the social part, she lived outside Buenos Aires, Argentina, in the countryside, around 600 kilometers from Buenos Aires in Bahia Blanca. She started 2 months prior her first consultation with isolated episodes of enuresis associated with abdominal distension and later on abdominal pain. The first consultation came 2 months afterwards. It started with an abdominal ultrasound that was made at her hometown. It referred at abdominal mass that had displaced the left kidney. Okay, can you pass the next one, please? It was followed up by a pretreatment CT that said that it had in the left renal cell a voluminous heterogeneous solid formation that incorporated the contrast. It displays the renal parenchyma to the contralateral side. It measured up to 150 cubic centimeters and displayed the midline surface beyond it. It has partially incompressed anterior margin of both abdominal aorta, inferior vena cava, and the regional of both renal arteries and left renal vein. In the thorax CT, we had no evidence of any metastasis. Next, please. Well, with a high suspicion of a Wilms tumor, we started under the umbrella protocol with a preoperative chemotherapy, which consists of 4 weeks of vincristine and 2 weeks of actimomycin. Next, please. For the surgical part, she came to Buenos Aires to Hospital Pedro de Lizalde, where we have done the post-chemotherapy pre-surgical CT, where we can see that it had really good response. The mass described was persistent in the middle and lower pole of the left kidney, which decreased in comparison with the previous CT. It measured up to 27 cubic centimeters, which was a 95% response to the chemotherapy. Next, please. So it came the time of the surgery. Well, we had a little bit of difficulties with the travel for our patient. Like I told you so, she lived in another city, she had to travel. That's why she had to receive an extra vincristine because we were in a time lapse that was not very well solvented. And as a post-surgical complication, she had diarrhea with a secondary triglyceridemia. Next, please. We have the local pathology, and that said that the left kidney, the adrenal gland, and the left urethral had a regressed nephroblastoma with an 84% of necrosis that led up to an intermediate risk that was a stage 1. Non-infiltrated adrenal gland and the left urethral all were clear. Adrenal nodes were negative. Peripheral fat also was free of neoplastic infiltration, and the intercalated aortic nodes were negative. Next, please. With all these, we had the diagnosis of Wilms tumor with a stage 1 intermediate risk, which led up to the chemotherapy that only consists of 4 weeks of vincristine and 1 actinium. Next, please. But under the umbrella protocol, all our biopsies go to central review pathology. This one differ a little bit with the local review, and it said that renal parenchyma had neoplastic proliferation consisting of 64% stromal elements, 6% epithelium, and 30% blastema, with regressive changes that were observed in 57%. Soft tissue involvement and renal sinus was observed with viable tumor. Also, it had 2 sectors that showed viable tumor reaching to the superficial margin. No nephrogenic remains or aneplasia were observed. With this, our diagnosis can change a little bit. We have a mixed nephroblastoma, also an intermediate risk, but we passed from stage 1 to stage 3 because of the viable tumor and that was in contact with the surface. Also, no nodes were involved, but we have to change our strategy. Next, please. With this, we pass from stage 1 to stage 3, intermediate risk, and the chemotherapy passed from a 4-week chemotherapy to a 27-week chemotherapy with actinium and vincristine. Also, we had to think about the abdominal radiation that this patient had to undergo if we have a stage 3 tumor. Next, please. With all these, we came up with our friends in Brazil from the Renal Tumor Board to discuss the need of radiotherapy in this patient. Also because in the previous images, in the diagnosis images, it showed a rupture with free fluid in the retroperitoneal cavity and in the abdominal cavity. With this, it was agreed for this patient in this condition, we should assume her as an stage 3 patient. And she will have undergo 27 weeks of treatment, chemotherapy, and also a total abdominal radiation. Next, please. So in summary, from the first time the patient met the physicians, from her first symptom to the chemotherapy, preoperative, it had passed 1 month. Later on, she came to Buenos Aires, where we have done the post-chemotherapy CT, the surgical part, and had undergone all these to the local pathology, the central review. We had a tumor board discussion, so we can go and have the correct treatment for our patient. That will be all. Thank you so much.
Thank you so much, Debora, for this very clear presentation and also highlighting the critical role of pathology in deciding on postoperative treatment. Well done. And now it is my honor and pleasure to introduce Filippo. Filippo, who I, of course, consider a friend and who I think is one of the best, if not the best person to give this presentation today. He's been serving in SIOP for many years. He's also the Secretary General of the SIOP Renal Tumor Study Group and the chair of the committee for the relapse committee, and has also been serving as a friend and mentor for AHOPCA, and I'm sure there's some on the call on the meeting today. AHOPCA, the Committee for Wilms Tumor in Central America, for many years. He's also one of the leaders in developing the Wilms area guideline, the leaders especially in terms of local content and local context. And I think there's a lot we can learn from him today. So the floor is yours, Filippo.
Thank you very much, Trijn, for this so kind presentation. Can you see my screen, please? Can you give me a feedback?
Yes, we can see it.
Yes, we can.
Thank you. Thank you, Tree. I feel so glad and honored to be here today, and welcome everybody wherever you are. I would like to start, I would like to approach Wilms tumor from a slightly different perspective than the classical one we are familiar with, viewing at Wilms tumor as a paradigm of the great success of pediatric oncology, which remains true, I mean, we are happy, and we write in every single paper we write or we read that we are happy to be able to cure more than 90% of children in high-income countries. We are happy about the treatment until now, and still now, we can say that the backbone of the modern treatment of more than two-thirds of children with Wilms tumor is based on two very old drugs, actinomycin D and vincristine, which have been introduced in the market in the late 60s. So they are very old. They are not that expensive. We know rather well that they are not also that toxic. This is a seminal paper published in the New England Journal of Medicine a few years ago, very nicely showing us that for Wilms tumor, in the past 20 years, there was a gradual but significant reduction of mortality related and in parallel with a gradual reduction of the exposure to toxic treatments like radiation therapy, like doxorubicin. And this one, I'm referring to SIOP 2001 randomized trial, was one of the last steps with this attempt to get rid of doxorubicin. You may know that in SIOP 2001, there was a non-inferiority phase 3 randomized trial whose main goal was to see whether we could safely omit doxorubicin in stage 2 and 3 intermediate risk Wilms tumor. And the answer was yes, we can. So no inferior event-free survival, overall survival without doxorubicin. But interesting to note, if we go into a more deep view of this experience, like the authors did, the authors could make an internal comparative analysis between participating countries. And you know, the Brazilian group participated to SIOP 2001 trial, and Brazil is regarded as an upper middle income countries. Then event-free survival for the Brazilian group was significantly lower without doxorubicin compared to reference European countries. So the point is that can we avoid safely doxorubicin in all the settings? And then, I mean, we are happy we can cure more than 90% of the patients, but actually, great majority of children affected by Wilms tumor, you know that they do live in countries where expected overall survival is largely unsatisfactory, largely below 50%. And also from a knowledge point of view, we are able to cure the children, but we are ignorant as far as the biologic, the genetic mechanism underlying Wilms tumor. So recurrent driver mutations are not identified in most tumors, and also genetic predisposition that we can hypothesize in many children actually is not identified in great majority of patients. And also, if we think and if we look for new therapeutic targets, actually many of the most frequent genomic events like P53 mutations do remain non-actionable at this time. So we do not have new drugs. So, but I mean, taking these few initial slides, I have one good starting takeaway, that is we can make improvement in low resource settings without relying too much on fancy, expensive drugs. So we can improve with cost-effective strategies because we have the means, I think. Well, I don't want to spend too much time on clinical presentation, but I think that it is important also to share that what we regard as usual in high income settings may be unusual in other settings. Like we expect children, in most of the cases, asymptomatically, they are in good shape, they are not that sick, and in high income countries is rather unusual to have presentation like children who are very sick with an acute abdomen because of rupture, because of bleeding, or with symptoms related to an extensive metastatic burden in the lung or in the liver, which are clinical pictures that we can see not that infrequently in low and middle income countries, because we know that there's a higher proportion of children presenting with huge tumors and with metastatic burden. I would like to spend a few words on which imaging do we need when we face a child with a suspected Wilms tumor, because we do not need so many scans. So we need to study the abdomen, and the abdominal ultrasound is still regarded as a very good tool. And then we need a cross-sectional examination of the tumor, either with a CT scan or if it is available, an MRI. And we need to study the lung better with an unenhanced CT scans. But my message is that we do not need anything else. So the PET scan, there is no evidence. Other scans, there's no evidence. So let me just briefly tell you why in SIOP, for instance, in the current SIOP umbrella, we are advocating to use more MRI comparing to CT scan, beyond the advantage of not giving ionizing radiation. Because there is increasing research with MRI trying to show any correlation between some advanced sequences like the diffusion-weighted sequencing with the response, the tissue response to preoperative chemotherapy, and hopefully also with the histological subtypes. Well, introducing to Wilms tumor histology, I have to remark how heterogeneous it is. And this is going to translate in a difficult life for the pathologists, because Wilms tumor is very heterogeneous. You can find different types of cells, and the pathologist needs to precisely describe and sometimes quantify each component. So the blastema, the epithelial, the stromal. This is even more complicated when you have preoperative chemotherapy, because then you have also chemotherapy-induced changes. And as Debora showed, the pathologist need to describe and to quantify. And most importantly, the pathologists need to look for anaplastic cells, which is tremendously important. So this is the reason why the role of pathology in Wilms tumor is so key important. And pathologists not only, they do not need just to pick one sample of the tumor and say this is Wilms tumor. They need to go through all the nephrectomy specimen and try to describe all the components in all the tumors, sometimes also to correlate with the anatomy of the kidney. Well, intratumoral heterogeneity, for instance, is one of the primarily underlying reason why we fail to identify anaplasia. Because, if you take only one sample of the tumor, for instance, within this big red plot here, then you are lucky because you can say this is an anaplastic tumors. But if you take only one sample within the green area and there's tumor, then you call this one non-anaplastic tumors, but there's anaplasia. So you miss anaplasia. So why I like to remark this? Because anaplastic histology is still regarded as one of the most powerful prognostic factors, and most importantly, regardless of the initial treatment. So this is important both in pre-treated tumors and in primarily operated tumors. We know that anaplasia has an incidence of around 7-8%. I guess this might be even higher in low and middle income countries because of the diagnostic delay. Important to say, the definition of anaplasia is made by the pathologist. It's not a molecular definition. Also, we know that anaplastic cells frequently, up to 85% of the cases, have TP53 mutations, and so as a consequence, TP53 immunostaining can help the pathologist, but anyway, the diagnosis is morphological. So it's the pathologist who tells us, looking at the slides. We know that anaplastic tumors usually present at more advanced stages and in older children. I mean, apart from the intratumoral heterogeneity, it's also a matter of the expertise of the pathologist. So my friend Gordon Vujanic always reports that even in the context of a well-organized scientific association like the Children's Oncology Group or the SIOP Renal Tumor Study Group, we have discrepancies as far as stage assignment and histological risk group in a range of 10 to 30%. So which is high. So this is the reason why hopefully rapid central pathology review is so key important. So I will try to introduce some principles of treatment, and especially thinking of low and middle income countries. So as you may know, there are, I would say, two most common strategies to initially treat and face a child with a suspected Wilms tumor. The SIOP one, I mean, the strategy of preoperative chemotherapy, which was born in the context of the SIOP Society, which advocates the use of preoperative chemotherapy systematically, almost in all the cases, with few exceptions. And then, important to say, the evaluation of the tumor is of a tumor who had received preoperative chemotherapy. And so prognostic factors and the decision of postoperative treatment rely on a primarily treated tumors. On the other hand, we have an approach which is based on primary nephrectomy, which was born in North America in the Children's Oncology Group, which in principle advocates with primary nephrectomy, but there can be some options for preoperative chemotherapy, and then postoperative treatment is mainly assigned on a tumor, on a chemo-naive tumor. So, as you can imagine, one question that always comes from when you say that you need to use preoperative chemotherapy in all the patients, one question is, do we need to biopsy to be sure that we are facing a Wilms tumor to correctly start with preoperative chemotherapy? Of course, as you may imagine, this is a burning issue within SIOP. The answer is that now we have relative evidence, then we have some guidelines to guide when to use biopsy. And one main factor is patient age, because it's epidemiology telling us that, and this is a nice picture by Kaio Nakata, an epidemiologist from Japan, showing us that the age where you see a significant reduction of the incidence of Wilms tumor comparing to other non-Wilms tumor, like the purple line is renal cell carcinoma, is at around 10, 11 years. And our UK colleagues who had an extensive experience on the use of biopsy could tell us that in children aged over 10 years, a biopsy correctly changed the management in a relevant proportion of patients. So taking this piece of information, now we have a rather clear guideline to decide when to biopsy, which is not only but mainly based on patient age, together other factors, because age in turn reflects epidemiology of the relative tumors. And this is also the reason why, if we think on a global perspective, we need to know epidemiology in each country, because, for instance, we know that incidence of Wilms tumor is significantly lower in East Asia, for instance, comparing to North America, Afro-American ethnicity children. And also the age of onset in Asia is younger, so underlying probably a different genetic mechanism. But this is to say, to me, this is important, because if in South or in East Asia, we have a proportion like 70% Wilms human and 30% non-Wilms, we need a little bit to adapt the SIOP guideline to biopsy. So we need to transfer informations in the context of the local epidemiology. This is also interesting, that I think that we are experiencing all over the world an increase, for instance, in the last 20 years of renal cell carcinoma. This is for environmental factor mainly. So coming to the SIOP approach of the preoperative treatment, I think that we can identify some advantages. Advantages related to the patient, because we know that preoperative chemotherapy reduces the risk of surgical-related rupture and induce a more favorable distribution of stage in favor of stages 1 and 2, means less postoperative treatment. But it is also important to select good responders. I will show you in metastatic patients. And second point, to identify some high-risk histology, like the blastemal type. And then last but not least, through a systematic use of preoperative chemotherapy, we may implement the rate of nephron-tearing surgery, for instance, in bilateral tumors. Well, I have to say that, I mean, beyond any philosophy or any protocols, there is anyway a global consensus on the fact that chemotherapy is beneficial in metastatic tumors, in bilateral tumors, or in children with predisposition, and in those tumors with a cava thrombosis. So if we use preoperative chemotherapy, that means that the pathologist, as I was saying, need to clearly quantify, first of all, how much tumor has changed because of chemotherapy. Then he or she needs to identify the anaplastic cells, and then looking at the available tumors, they need to quantify each different cell type. In that way, we have the histological risk classification systems of pre-treated tumors in SIOP, where we have now low-risk tumors, including the completely necrotic, so 100% chemotherapy-induced changing. On the other hand, we have the high-risk tumors, the diffuse anaplastic, the blastemal type, and in the middle, we have now a rather heterogeneous group of tumors we call now intermediate risk. But I want to tell you that there is some research going ahead in SIOP. Try, for instance, to see where some of these tumors, some subgroups, for instance, like the epithelial type or the stromal type, stage 1 and 2, maybe can be moved to a better prognostic subgroup. So to remark, I think that another takeaway from this is that the approach to neoadjuvant treatment of Wilms tumor provides a unique opportunity to in vivo assess the response of each child. So in other words, this is sort of cost-effective, personalized medicine. This is also true for metastatic patients. So these are data from our previous Italian study, where you can see that those children with lung metastasis on your left, but displaying a complete response to preoperative chemotherapy, the blue line, they had a significantly better event-free survival and overall survival than those without a complete response, and important to say, without the use of radiation, lung radiation therapy. So, in other words, now the presence of metastasis is not per se a criterion, a negative prognostic factor. So we should look at metastasis as a dynamic prognostic factor. So we do not know whether a different initial tumor burden matters. We do know that what matters if the metastasis completely responds, so if they are chemotherapy response. And when we take the metastasis out, also the histologic response. This view is important to decide whether or not to use radiation therapy and whether or not to use different cumulative dose of doxorubicin. Well, coming back to the localized Wilms tumor, in the current umbrella approach, so the post-operative treatment relies on 3 groups of factors. As I told you, the histology of the tumor, the stage, and last, the tumor volume at the time of surgery. Why the tumor volume? Because we had a post hoc analysis, a martingale plot analysis on your left, in cases treated within SIOP 2001, showing that with a tumor volume bigger than 500 milliliters, we had a significant increase of relapses, which translated in a significant different event-free survival. So those children with tumor volume more than 500 milliliter had a significantly worse event-free survival. And importantly, as you remember, in SIOP 2001, we had the randomized question as far as doxorubicin. So we had the chance to look at children with tumor volume more than 500 milliliters treated with or without doxorubicin. And conclusion was that from this post-hoc analysis, that children with bigger tumor volume, more than 500 milliliters, the green line on your left, treated with doxorubicin did better than those treated without. So we had an insight on the fact that doxorubicin is maybe important to have when you have biggest tumor. But I mean, 500 milliliter is a cutoff of volume of tumor surgery, is a cutoff that we have studied in the context of SIOP. So the point is how we can transfer this information in the rest of the world. So this is a seminal paper published in Lancet many years ago, which is very inspiring. I mean, although we may consider, we may hypothesize different doubling time for Wilms tumor, but then we can say that with a diagnostic delay in the range of a couple of months, which is not that unusual in low-income settings, then we face tumor volume at presentation in the range of 30, 40, hundreds milliliter. So this is important to keep in mind. I have tried also to complete this table, and please send me if you have any data on the tumor volume at diagnosis in different settings. Because as you can see here, when we talk about tumor volume in Europe, in the context of the European SIOP countries, the initial tumor volume is in the range of 300 milliliters. And following my previous slide, this was significantly higher during the COVID crisis, during the lockdown, where we could experience delay in the diagnosis. And as you can see here, in other less research settings, tumor volume at presentations is bigger. So my point is, if we want to take one factor like tumor volume to be a prognostic factor, we need to know which is the local prevalence, because we need to know how many patients we are going to overtreat because of that factor. Because look at that. In experience we have in Central America, around 60% of children present with more than 500 milliliters tumor volume. That means that we are going to overtreat a significant, relevant proportion of patients. Well, also in connection with the tumor volume, let me go a little bit back to the best preoperative chemotherapy regimen for SIOP. So where comes from the current SIOP 4-week preoperative regimen? It was in SIOP 9 trial with randomization, 4 weeks compared to 8 weeks of treatment. And the first answer was 8 weeks, so prolonging preoperative chemotherapy in localized tumor to 8 weeks, no advantages in terms of a better stage distributions comparing to 4 weeks. But then when they look at tumor volume reduction, they could see that on your right, after 8 weeks, they could observe a significantly better tumor volume reduction. So the point is that if we face tumor with a big volume, like in less research setting, maybe the use of preoperative chemotherapy, prolonged preoperative chemotherapy can favor a better volume reduction to arrive at surgery with a smaller tumor. A few words about surgery, because you know that surgery is a key step towards the cure of a child with a Wilms tumor. Conventional surgery is nephrectomy, but with adequate lymph node sampling. So now it's plenty of scientific evidence saying that if we do not sample lymph node, survival, event-free survival is worst. And this is likely due to understaging, which in turn affects the intensity of an hopefully stage-directed therapy. And we know that all over the world, there's a rate of failure to sample lymph node in the range of 10–40%, depending on different settings. For instance, if you look at the Children's Oncology Group, which is a well-organized scientific association with very good surgeons, very expert surgeons, this is the lowest range, 10%. But important to say, my experience, for instance, with the Central America AOPCA group, the rate of failure to sample lymph node could be reduced from around 30% in the first period to 20% in the last period through, let's say, activities of educating surgeons together with the clinicians participating to share the clinical tumor board. And this is important. I found it very interesting. This last paper published on this month on pediatric blood and cancer from Asia Pacific surgeon. He made this very interesting analysis survey to surgeons. And one question was, what is your routine practice on lymph node sampling in renal tumors? And only 40% of surgeons did answer, yes, we routine sample lymph nodes. So it's a matter of a need of increased surgeon education on the importance of lymph node sampling. Also because surgery is not a therapeutic, is not only a therapeutic action, is also instrumental tool for local staging of the tumor. So it's going to give us clinicians so many important information to guide postoperative treatment. So in summary, in this table, I've tried to summarize which prognostic factors are used across the most common protocols, the SIOP and the COG, and how we might consider to implement in the context of less research settings. So stage, I think it's important. Despite there is difference in stage definition between SIOP and COG, but stage is universally important, like it is the presence of anaplasia. Histologic response to preoperative chemotherapy, I have tried to show you that this is a cost-effective, important tool, which is very well now incorporated in SIOP. Also in the Children's Oncology Group, for instance, in bilateral tumor is going to take into consideration. And I was wondering how to implement this also in low and middle income countries, because is a matter of educating pathologists is not that expensive. You know that molecular factors like the loss of heterozygosity 1p16q are not yet included in SIOP. They are under investigation, apart most of all 1q gain. And the Children's Oncology Group is implementing the current risk stratification by incorporating also 1q gain in the next generation of protocol. Patient age is a known factor within COG. I don't know how we can consider in a certain sense also to adapt in low and middle income countries. I have shown you that tumor volume, I think, might be also a cost-effective prognostic factors, but we need to do local studies to see which cutoff and completeness of lung node response, which is actually not fully taken into consideration in less research countries, because our attitudes is to give radiation therapy anyway. But I think there's room of improvement for those patients with a very rapid complete response of metastasis. And then, of course, we need also to consider additional factors like malnutrition to also as a prognostic factor. But important to say, I think that every type of prognostic factors we want to implement, they are contextual, not only to the treatment, but also to the socioeconomical setting. So this is to show you that 1q gain is going to be a good adverse prognostic factor, which is going to be implemented in the Children's Oncology Group and is under final analysis within SIOP. So concluding, let me also share a couple of thoughts on relapse. The tumor, you know, I am a supporter of relapse treatment. But I think that it is also time to ask us these questions. How treatable is relapse Wilms tumor also in the context of less research settings? I don't have an answer. I think there are two possible answers. The first answer is that we do not know, because there's no evidence, there's no study. I've never seen a paper describing the post-relapse outcome in this context. But I can understand that we have other, priorities. But the second answer, it might be, yes, it is curable, because one main reason of failure is initial undertreatment. You know, these are data from SIOP 2001. In absolute numbers, the great majority of relapsing patients comes from the patients treated initially with a minimal only VA treatment. So I think that the first task in less resource countries is to ask, can we identify a group of patients who are curable because they have received a minimal frontline treatment, and start to think of them. So my final simple, but I would say clear sharing is that, first of all, one important thing is that thanks to standardized clinical and surgical protocols or guidelines, this has been shown to be one of the most impactful and cost-effective means to optimize outcome and advanced tumor. The second point is that we need research. We need local research, because only thanks to research we drive to progress. And last but not least, we need a continuous education of pathologists, of clinicians, of radiologists, of surgeons. And SIOP, I think, that can offer this, like this webinar today is trying to do. So let me thank many people actually that contribute to this development. I would like to thank my colleagues from the Renal Tumor Study Group, Mary van der Hervel and Arnaud, the chair, and Gordon Bujanic, who also was always available and inspiring. My colleagues from the Central America HOP, Catelma Velasquez, who is the chair of the group and also the mentors. My colleagues Michael Sullivan and Manu from the Wilms Tumor Area Guide. Of course, Trijn, who was also so educational to myself, and she knows so many things. Colleagues from the Children's Oncology Group and from our Italian group, and also Kathy Pritchard-Jones, who was a mentor of myself in many different experiences. And thank you all for listening to this webinar today.
Thank you so much, Filippo. This was an excellent presentation. At least for me, I really enjoy it. I just have some comments and questions from the audience right now. One of them is from Alejandra Casanovas. She's like taking your point about the importance of teaching pathologists, and she's sharing that in Gallup, which is the Latin American cooperative group, they are doing some lectures to train pathologists with Dr. Bujanic. So if anyone is interested in participating in those lectures, they can let us know and we can just like make the connection. And then there is a question from the audience that is asking about the approach in cases that present with tumor rupture at presentation. Should they undergo surgery or radiation therapy or chemotherapy? And then also asking about renal cell carcinoma, if they can dealt like renal tumors under the renal tumor staging that the SIOP group is doing, like rhabdoid tumors.
Thank you. These are two important questions. First of all, I am aware about the initiative in Gallup by Gordon Bujanic. I invite everybody, every pathologist to join. So the question as far as initial rupture is an important one. I think that I do not have a single answer. The answer is that it depends very much on the clinical presentations. So now there's an attitude towards being more conservative. If the child is not that sick, it's better to start with preoperative chemotherapy anyway to stabilize the child and try to go through preoperative chemotherapy to surgery. And I have to add that the current definition of rupture in the context of pre-treated tumor is not done at the time of diagnosis, because sometimes you can see a very good response and the definition of rupture is made at the time of surgery by the pathologist. So my answer is, it depends very much on the clinical situation. If the child is very sick, he or she is bleeding, then our attitudes is try to do some conservative approach like embolization to stop bleeding. But I would say a general answer is let's use chemotherapy anyway, because in my experience, above all, if the patient is in the context of a less resource settings, they can improve and then arrive to the surgery. So concerning the second question on renal cell carcinoma, so renal cell carcinoma has a different staging than Wilms tumor. Renal cell carcinoma in children and adolescents is staged with the TNM staging system, which is a little bit different. And of course, it requires a completely different approach. What I would like to remark is that there's a big difference between localized tumor, even local advanced tumor, where surgery has still a good chance of cure the child. So I would invest on those situations. But children with presenting with renal cell carcinoma with metastasis as presentation, unfortunately, children and young adults, they do not have any chance to be cured in regardless of the context. I mean, even in high-income countries. What we can do by administering different lines of expensive drugs is to prolong the progression-free interval. But there's no chance. But if the tumor is localized, surgeons has a key important rule.
You're muted, Trijn.
Great presentation, Filippo, and also quite a few questions in the chat or in the questions section. I think we're also almost running out of time, so we'll try to answer questions after the meeting. But maybe to summarize a few for you as, I guess, a last question. What are your thoughts on recommending the preoperative chemotherapy approach for resource-limited settings anyway, patients living there, considering the contextual factors? And if you can, in a relatively brief answer, are there any adaptations in terms of either prolongation or reducing intensity that you would consider? Thank you.
Thank you so much, Trina. I think this is a key question. I think this is a key question. So to summarize my answer, as you can imagine from my presentation, I have tried to show that the advantages of preoperative chemotherapy are evident to be used, preoperative chemotherapy, to be used in the context of large resource countries because of all the advantages that I have tried to list. And last but not least, because we have I wrote a sustainable, so a cost-effective way, which is a prognostic factor. So we know that a tumor responding to preoperative chemotherapy, we can allow a reduction of treatment. Tumor not responding, we need to intensify. So I would envisage the use of preoperative chemotherapy in this setting. The issue of how to adapt is a key one. We need to adapt in terms of duration. I think this is a very important issue because there we need a balance between not prolonging too much, because by prolonging too much, sometimes you run the risk of increasing the rate of abandonment. But sometimes prolonging, as I show you, may be helpful to reduce the tumor volume. And so this is important. And as you, Trijn, taught me, also adaptment of the dose of each administration. So I think that one big effort is try to figure out how to adapt the dose to the different clinical presentation, malnutrition, infection, to use the same drugs of increased actinomycin with or without doxorubicin in some context, but adapting each drug dose. Or sometimes delaying a little bit the interval. Instead of 1 week, maybe 2 weeks or 10 days.
All right, I guess we're running out of time, but we have time for one more question. So there's Debora, can you mute yourself? And there is a question about how to treat Wilms tumors when the patients receive neoadjuvant chemotherapy and abandon treatment. before surgery. So even if the disease is still localized, is it better to give VA increasing actinomycin chemo before surgery or to add doxorubicin for patients that abandon treatment?
But you mean if the patients come back after abandonment?
They come back after that. There is like a gap. I understand based on this question, there is a gap between the initial chemotherapy and the time of surgery.
Well, I am afraid I have not an answer to this question. So my personal opinion is that it depends. If the tumor was very responsive to VA, then I would try to go ahead with the same two-drug combination. If when the patients came back has a much bigger tumors, then we can also add doxorubicin. I think that we do not have a just one answer. We need to adapt to which is the situation when the patient is back. But to resume the same two drugs, chemotherapy sometimes is effective as to intensify other treatment. So if the patient is very sick, maybe it's better to just to restart with the two drugs chemotherapy.
Okay. It brings us to the end of the session today, which has been a very, very educational. And I think we could go on for hours, but there's more to do. Any unanswered questions will be answered by email. Many, many thanks to all of you for joining and contributing to this engaging discussion. Of course, many thanks to Filippo and Debora for great presentations. To SIOP, Anelia, Suzanne for facilitating these sessions. I think DiSPLeN is really filling a need for education on these common and curable cancers, also seen by the participation today. And if I may, a special thanks to Sagir, who is doing a lot of work in the background to make this initiative to a success, as he has been doing for Global Health Network and other programs of Global Health Network previously. And to Gabi, my co-moderator. And all have a very good day, and thank you so much for joining.